Good afternoon, everyone. So we'll be starting with this session, which is basically about children and pediatric ophthalmology. And so let's call upon our first speaker. It's regarding the pediatric cataract surgery in challenging situations. And we all know Dr. Jagat's contribution in this field. So I invite Dr. Jagat, sir, for his talk. Time given is 7 minutes, but we have only 4 speakers for the entire session, so we can take more time, sir. Are you okay with 7 minutes? Do you want more time?
It is fine. I think I had that 9-minute talk, but I have reduced it to 7 minutes.
So we can take it because we have only 4 speakers in this session, so
yeah.
We can.
Thank you very much.
Yeah.
Chair, co-chairs, and moderators and friends. I will be speaking on pediatric cataract surgery in challenging situations. While these children come to us, we have to examine each of the child. Majority of the children, they come with visually significant cataract. And then we have to examine each of the child after dilatation, that which type of cataract is there and what should be done. Then only then you can find the difficult situations. And what is our goal of pediatric cataract surgery? Goal is to find a clear visual axis and visual rehabilitation. That is the long-term visual rehabilitation. And then I will show some of the situation. First I will be showing normal pediatric cataract where it is a zonular cataract. What we have to do? We have to diagnose, plan, innovate, execute, and find out the complex pediatric cataract and operate them and have long-term follow-up of these children. First, I think I would like to show a small clip of zonular cataract. This is a child with zonular cataract, classical zonular cataract. To demonstrate, I think, or otherwise also, stain the anterior lens capsule with the trypan blue dye and make continuous curvilinear capsular axis. Size of the axis is kept around 5 millimeter or so. If you try to make large, it will be very large. So make precise about 5 to 5.5 millimeter axis. Irodissection followed by removal of the cortex from the capsular bag, and then usually in children less than 6 years, sometimes even less than 8 years, we make primary posterior capsulotomy. Size of the primary posterior capsulotomy is kept around 3 to 3.5 millimeter. If you make very large, it will be difficult for you to place the IOL. So here we are trying to make about 3.5 millimeter axis, and then you do limited anterior vitrectomy in the zone of rhexis, then implant hydrophobic acrylic IOL in all cases. Previously we used to implant even PMMA IOL, sometime even now, but majority of the cases is hydrophobic acrylic IOL. So this is after surgery, and don't forget to place suture at the main incision. Then comes pediatric complicated situations such as PHPV, posterior lenticonus, ophthalmology, juvenile idiopathic arthritis, uveitis. Here is one child with classical posterior lenticonus. here I have done anterior segment OCT, which shows that there is a posterior capsular tear, and then making continuous curvilinear capsulorhexis. Then limited hydrodissection. If you do very vigorous hydrodissection, you will find you will create more disturbance, because there is a already PCR, posterior capsular rupture. So here I have done more carefully, and as expected there was a PCR, and then IOL is implanted into capsular bag. And whatever I think vitreous is there in the this site of the rupture, pre-existing rupture, that is cleaned, and surgery ended with and this is 8 months after clear visual axis. This is anterior segment OCT. And then comes another child with juvenile idiopathic arthritis, having 360-degree posterior synecdoche. In such situation, synechotomy is done, and then place Malaysian ring or any other device to adequately dilate the pupil. But we must know that how to place this Malaysian ring. This is easy to place, not difficult. Staining was done, and this is continuous curvilinear capsulorhexis. This is phacoaspiration. It actually you can do with the IA also. And here is placement of IOL in the capsular bag. And sometime in such patient where there is 360-degree posterior synecdoche, we do a small peripheral iodectomy, not in every case. Then come this child with congenital lenticular coloboma. Here it is not question of placing the IOL, it is a question of stability of the IOL bag complex. What we ultimately want to achieve. So here in this situation we have to place capsular hook. These are the capsular hook, and then synecdoche was also removed, and then removal of the cortex from the capsular bag. And this is for stabilization of the capsular bag. This is a pair pack suture, and this is single eyelet Sioni ring, which is placed in the capsular bag, and it is now it is the final position where we will place it. And then this is in this case, because toric IOL was placed, this is Callisto we are using, and final position of the IOL, and this is after removal of the hooks. This is before and after surgery. This anterior segment OCT also. So here this third child come this with double crystalline lens. I think you must have seen this video at many of the places. This is a child who had united cornea, two cornea joined together. There was junction in the center, and there were two crystalline lenses. They were separate crystalline lenses, and we planned a customized IOL for this child. And this was a 18mm long customized IOL which was made by Care Group. Actually you will find hole in the haptic, because I thought that if I fail to do place the IOL, then I will do transscleral fixation of IOL. Second choice was also kept. This child could see. This was a long-term follow-up video. Amblyopia therapy was given. Child is seeing through the affected eye. You can see the cornea, how it looks like. Then comes another difficult situation, or where we say persistent fetal vasculature, or we also say primary PHPV. Rhexis is made, then cauterization of the vascularized membrane, and then we have to make capsulotomy and place IOL. Difficult to cut with the vitrectomy cutter, but it is quite thick membrane, and this is cauterization of the stalk, and removal of this stalk so that there is no bleeding after cauterization, and placement of IOL, because it may be difficult to place IOL directly into bag, so it is captured, optic is captured into capsular bag. So these are some of the other, these are animations and some of the other classical cases of PHPV which we have operated. And these are other situations, and these are some of the publications. Lot of number of children they are operated and documented, and this is to show one child operated in 1997. That time it was just starting of primary posterior capsulotomy and anterior vitrectomy, and this is followed for 25 years. In 2000, only last year, he he completed his MBBS. He is a doctor. He is a E-metro. He is myopic by I think 1.25, 1.5 diopter. So long-term follow-up is important. Just in shortly, I will tell some of the proudest moment. This will take not more than 1
डॉक्टर
minute.
जगत राम चिकित्सा नेत्र विज्ञान.
And received best of the best award at ACRS, 2 times winner award 1 time, and Oscar of Pediatric Ophthalmology. So this was also proudest moment for me. Thank you very much for giving me this opportunity. At present, this is after retirement. I am working here at Grewala Institute.
Thank you, sir. Thank you for your excellent presentation and the vast variety of videos which showed all types of pediatric cataracts which we deal with as pediatric ophthalmologists. Sir, anybody has any questions for sir? Anyone who wants to ask something?
So, do you have an age cutoff when you will implant an IOL after pediatric cataract surgery?
Yeah, definitely. Those first we have to find out that which cases are fit for implantation of IOL. Ideally, it is 6 months or so. That less than 6 months, one may not do, or one has to be very careful. Although I have operated even 1-month-old child, and I have followed that child for long time, more than 15 years, because if there is no microphthalmos, axial length is more than 16.5 or 17 millimeter. If it is a unilateral cataract, even less than 6 months we implant IOL. But where there is a contraindication, I think you should not implant.
So I agree with sir, especially in unilateral cataracts, you can think of lesser than 6 months. For after 6 months, every child should be implanted with an IOL, provided there are no contraindication, says there is no microcornea, there is no microphthalmos. The bag has to be there. Otherwise, you'll have to get a custom for the double thing. Otherwise, obviously, you cannot induce secondary glaucoma. That is the biggest risk which we have if we implant a normal size IOL in a pediatric age group with a smaller. So that is the first thing. So second, because I had done it as my own thesis, I remember. So what is your take on doing posterior optic capture in very, not very young children, obviously, because there I would prefer to do an endovitrectomy.
PCO?
Yeah. No,
Yeah.
so
Posterior optic capture. Most commonly I do in the bag implantation of IOL. That is number one. Almost 85 to 90% I do in the bag. Sometime there are optic capture two type.
yes. So I'm
One
talking
is
about posterior optic capture. I'm talking about
posterior capture. Posterior capture means that your IOL
It's going behind-
haptics
behind
are
the
in the bag and optic is behind in the posterior capsule.
in the individuals.
That I do less than 1% or so. That is also excellent.
So
But
actually, what was my experience in my own thesis, and I still
Yeah.
follow that, was that very young children, obviously the vitreous is very active. So in those, even in my, like it was exactly the Gimbel's technique which I had followed. And in that, what I had done was we had compared two cases where we had not done vitrectomy and where we had done
yeah,
without
that
vitrectomy,
will
we had done posterior optic capture, and in the other group we had done vitrectomy.
Yeah,
So the one with the vitrectomy obviously will not have the vitreous obstruction.
Yeah.
But the age group was a very important aspect in this. The children who were younger, less than 3 or 2 or something like that, they all, despite a posterior optic capture but no vitrectomy being done, they developed a piece of opacification in the vitreous face, which did not happen in the other group, which are older.
Yeah.
So that's why doing, you can do without a vitrectomy in older age group, but obviously PCC is a
Yeah,
mandatory, and
definitely.
you can optic capture helps in that, in which the basic thing is that the size of the IOL and the size of the posterior axis in that case has to be very accurate. It has to be only 1 millimeter overlap, less than the size of the overall optic of the lens of the PCC, so that it leads to a very, very tight apposition between the posterior capsules to prevent the migration of the lens epithelial cells into the vitreous cavity.
Now I fully agree, and even we do primary posterior capsulotomy less than 6 year or more less
that
than
we are doing
8
in
year.
almost every
But even then, don't say that 100% people
no,
will be
100%
having
not.
clear
I
visual
can
axis.
understand.
Even then, children get PCO.
Yes,
There
vitreous
will be ACO. There will be some
ACO,
membrane over the IOL surface, and there may be PCO. 10-15%. Still, they will get.
And sir, another thing, what is your take on putting IOLs in the patients with JI? Juvenile idiopathic arthritis.
Juvenile?
Idiopathic
Yeah.
arthritis.
One case I showed, that is fine. But otherwise, we have to be very, very careful that which type of inflammation is there, whether it is a recurrent or which type. So very carefully, it is a very controversial also. And prognosis remains, it has improved because we place IOL and we deal under follow-up, and because they may get recurrence or they may get glaucoma, chances are very, very high. But one has to be very, very careful. If you are experienced, careful, and then I think one can
So
go
would
ahead.
you do a PCC in these cases? Would you do a PCCC in these cases, posterior rexis?
Yeah, no, in the bag implantation of IOL.
No, in the bag is okay, but would you be doing
Primary posterior capsulotomy.
yeah, primary posterior
surely,
rexis you would be doing.
surely, sure.
So because I have seen, like I have operated several cases of GI, but recently I had a case which after doing posterior rexis, I don't know whether that is the reason, but he developed severe vitritis, severe optinitis for 6 weeks. He was perfectly fine. After 6 weeks, he landed with severe inflammation. He had to shift it to biologicals. He was on methotrexate when he came to me for surgery. And he's shifted to biologicals. Then he developed immune keratitis with the biologicals. So he has kept on developing one or the other immune complication. One after
They
the
are
other.
very, 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 very carefully we have to do. I don't say that 100% we want to, we have to take consultation from our uveitis
Yeah,
clinic people
rheumatology
also.
rheumatology people.
One should not think that I know everything.
No, no, sir,
I may
rheumatology
not know
people have
because
to be there.
they may, rheumatologist also,
Yeah,
because
rheumatologists
very
have to be
difficult
there.
situations. No, the excellent question. Actually, I had 2-3 video that is beside the point. I thought that I will show one video and those band shaped keratopathy. I have all the videos. Even there, our uveitis clinic people, our consultant will say to inject Azuredex injection, Dex implant, and these patients are followed by us and them also, our vitreoretinal and uveitis clinic people. So this is a truly a, out of all the cases, this is one of the most difficult situation. One has to be extremely careful. I don't say 100% that okay. Whatever you do, I think initially for few months it will be fine. Afterward, there will be lot of issues. I have few documented cases and full of pediatric JIA type of inflammation, classical. But here I have shown only one case. Okay, thank you so much.
The main thing is, I think with GIA is you need to have a proper screening program. Because
Screening, they develop cataracts. They usually develop cataracts.
Telling is in UK, once they are diagnosed with GIA, they basically put it into a screening program. They come every 2-3 months, and then they are put on methotrexate very early, so the chances of complication are slightly reduced. And then before you operate, at least 3 months, it should be disease free completely. There should be no inflammation for at least 3 months.
So now I welcome Dr. Vinita to present on a topic AI in Pediatric Ophthalmology, a drone's eye view.
So I'll be talking about something which is obviously making waves in ophthalmology because our science is so much image-based. We have lots of things which can be done with images and with, especially with the IL power calculations and so many things in the field of retina, in the field of glaucoma. And obviously, pediatric ophthalmology has all diseases which are there in the adults. But so any technique, as we know, artificial intelligence is any technique that enables computers to mimic the human mind. So artificial intelligence, we know, is not new. It was there. All these movies are an example of this, that it has been existing for years together. For pediatric ophthalmology, we have had several studies, several applications, several algorithms which have been developed related to ROPs, pediatric cataracts, strabismus, for vision screening, visual rehabilitations. And again, most of them are based on ophthalmic image analysis, which could be slit lamp images, which could be fundus images, and certain visual rehabilitation programs, which are based on other computer-based applications. We have to understand that in pediatric ophthalmology, the visual development occurs till 7 to 8 years of age. That's a very, very prime period of visual development. And any disease which affects the child eye in this period is going to lead to loss of amblyopia if not treated properly at that point of time. And these ophthalmic diseases which are affecting the children, their prevalence, their diagnosis, their treatment, their presentation is not exactly, the diseases spectrum is the same, but their presentation and all the other things are not the same as that for an adult eye. Even for congenital glaucoma and for congenital cataract, as Sir showed initially itself in the first presentation, retinal imaging also differs a lot because adult will cooperate, child will not cooperate. When we are doing it under GA, when we are doing it any OCT, anything, any image capture under GA, again, we cannot make the eye move in all directions. It's not possible to get exactly coaxial images. So all those problems which are there when we are capturing images for these people. Also the fundus for the vessels and segmentation in the fundus, especially when we are doing the images for the ROP, is also very different, and the classification is comparatively difficult as compared to that for an adult vasculature of the retina. Also, next set of problems is we usually get one exam. We don't get to do multiple exams as we can do in an adult, because we cannot every time subject the child to repeatedly for examinations under anesthesia for this purpose alone. So stronger reliance is done on the objective exams rather than the subjective exams in these cases. Children attention span for for more senior children or for school-going children, again their behavior is unpredictable and lots of examinations may be required. So if we are able to get good tools, good algorithms, good apps through AI, that will cut short our work, that will cut short the GA time as well as the GA exposure and overall improve not only the pediatric eye health, but also the overall health of the child. So this is what we are looking for when we are trying to develop tools or algorithms for AI in pediatric ophthalmology. But most of these tools still need a clinical validation prior to the time when they can be deployed in patients. Let's talk about AI in ROP. So potential is there in improving the ROP care, in the efficiency, accuracy, and the objectivity of the diagnosis, as well as for monitoring and the risk prediction of the cases which will develop the plus disease. As well as, but there are barriers. Barriers, as I said, there is a lot of variability in the examiner labeling one disease as a particular class of these, because every time the examiner is not capturing images for a screening. And also the total number of examiners who are actually well-trained is relatively less compared to a general ophthalmologist. So at present for ROP, there are 4 main computer-based diagnostic systems. One is the ROP tool, one is the image-based multi-skill analysis, one is a vessel map, and one is a computer-based, again, analysis of the retinal images. So these are the various studies which have been done, which have developed these algorithms, and which have tried to assess what is the efficacy, what is the sensitivity and the specificity of these tools. So most of the tools are capturing the retinal vasculature, and they're giving it a vascular severity score, which is basically used to compare and give it the grading of the ROP severity score based on that. And this is basically supervised type of machine learning. And the output is directly converted into a severity score, which is classifying it as pre-plus disease or the plus disease. Then this was the original IROP algorithm, which was developed, and its probability was given from 1 to 9, based on whether it's a pre-plus disease or the plus disease. Taylor did another work on it, and then he added and classified it further into no ROP, mild ROP, to match the clinical classification, type 2 ROP and the pre-plus disease, so that we could predict when to give treatment, okay, and which infants or the neonates are at a risk of treatment failure. But this requires to have the accuracy of almost 95% for this type of ROP apps, is that you have to have a good vascular tortuosity between the arteries and the veins. That has to be captured, and a very wide field of view has to be captured. And its clinical usefulness is therefore limited, because what we are trying to do is, initially for mapping, what is being done is manually. And again, as I said, the number of experts who are doing and trained for this are very relatively few, so obviously the sample size who is actually doing the manual work is very less. So obviously the detection of ROP versus no ROP, the sensitivity and specificity is very high, although the sample size is less, so hence clinical application of this is still pending. So this is one of the tools which shows how it goes about. So first of all, it checks for the pupil size, then it checks for the rubiosis, then it checks for the vascular status, and then finally it gives what is the zone or what is the stage of the disease, and whether it is a pre-plus or the plus disease. And then another two DL models which have been developed, whether the children have with ROP they need treatment. This is an add-on in this besides the screening tools. This is will also help whether they need treatment or not. And then they can also determine the treatment options for the children who actually need treatment. What is the treatment to be given? Then let's talk about the pediatric cataracts. Now, pediatric cataracts, again, requires expertise, especially for neonates. And again, the pediatric ophthalmologist number is relatively very, very less as compared to the total number of ophthalmologists in the world. And experts are usually concentrated in the specialized centers, as obviously Sir was from a specialized center. And hence, rural coverage is very, very less. So this lack of accessibility is very challenging, and maybe if we are able to develop something in the field of pediatric cataracts, it will be very good as an AI tool. So there are several tools which have been developed. One is a CZ Cruiser, which is basically measuring 3 main functions. It makes the diagnosis based on the slit lamp images, then does the risk stratification of those images, whether this cataract needs to be treated or not, and then gives the treatment suggestions. So automatically crops the images which are there from the slit lamp and tells whether there is presence of cataract or not, what is the grading of the cataract, and then gives a treatment recommendation whether the child requires surgery or can be followed on a non-surgical basis. And however, the real-world diagnostic accuracy of this is much, much lower than that of the actually experts. This is obviously because of the problems which we face with the children. We are not able to capture good slit lamp images. Eyelids and eyelashes come in between despite our best efforts to capture the images. And also, if the reflective image is not centered directly on the visual axis, again, the quality of the image goes down. And so the segmentation which is done by the AI development machine learning goes haywire. Another app which has been developed is for the post-pediatric cataract surgery patients to predict the two most common post-operative complications which we have in after pediatric surgery is the IOP, the secondary glaucoma, and the lens growth, or the PCO, as we call it in our clinical terms. So basically, again, there is a single module which has been developed for this. The first module of this will first develop whether the patient has a complication or not. Second module will then be applied if the first module says that the patient has a complication, to detect which of the two complications the patient has. Another approach is, again, to detect only the PCO. So that is another tool which is ResNet, which is there, which is being developed. Then we have another app, which is the CC Guardian, which is, again, serving three functions. It is basically likely to detect, it basically tends to detect the patients who are likely to suffer complications. So it has a dispatching module, a prediction module, a dispatching module, and a telehealth module. And the dispatching module will schedule the individual follow-up the patients at a regular interval by sending them SMS messages, so that they will come for follow-up, so that you can detect whether this child is likely to develop a complication or not. Because all the complications children will not develop in the first month. It's a long, drawn process. So dispatching module usually determines a follow-up schedule, as I said, and patients can complete the regular follow-up examinations in their primary health settings. They need not visit the tertiary center where they got their surgery done. So this is the advantage of this tool. And these are all the links which are there for how to upload your images for that tool sitting at the periphery. AI also has been used for detection of other pediatric eye diseases like myopia, strabismus, ptosis, by using a convex deep learning module. And the detection rate for this was 0.84% sensitivity for myopia. For strabismus was 73%, and for ptosis it's almost 85%. For strabismus, the prognosis in the treatment is important, and as a result, there are various tools which have been developed, again, by taking the facial pictures, by taking the 9-position gaze pictures, and by using mobile apps or by using the other cameras. And a CNN network has been developed, which takes these facial features as well as the ocular fixation from all the 9 gazes. And based on these eye tracking data is taken, or we can take the retinal birefringence scanning is done, which has a better sensitivity and specificity, which will then again be used to create a segmentation modules on each individual image. And these images are then classified based on the neural networks. Another tool is which is using only the Hirschberg test images, or the light reflection test as we call it. And this has if it works well, it will have a very wide application at the rural areas also. And it will be like finding a needle in a haystack amongst all the images. It will be very, very helpful. Like if we have so many images and if this tool works well, we'll be able to actually see which children actually are having strabismus and require immediate referral to the hospital for their further management. Then there is another tool which is measuring the versions. Version estimation application is there. Basically, it shows both the eyes are captured immediate at one go, and that is fed into the box, which is a predict eye version box. Then the training box basically predicts the eye version and gives it a corresponding confidence score, which is given at the bottom. So this is how it works. Guided backdrop, then it creates a cam image, and then this guided cam image gives the score. Then we have also been, as I already mentioned, it is being used for the diagnosis of strabismus, myopia, and it also used in the diagnosis of basic vision screening tool for detecting whether the child is having some visual acuity deficit or not. And that is very, very important for us, because lots of children come to us at a later age, maybe at the age of 16 or 17, when they are first diagnosed with amblyopia, especially for the anisometropic amblyopias. So in this, we have a decision tree, which is MLI classifier based. Can you just put that timer off? Yeah. So there's a classifier based on video frames that is basically combining the Bruckner's pupillary red reflex and an eccentric photorefraction tool. So these two video images are taken, and that is the basis which is used for detecting whether the child has a refractive error or not. So this is a dive version for this tool, which is then we have the role of AI in reading disabilities. So 10% of children have reading disabilities which goes undiagnosed, and abnormal eye tracking is important is an important aspect of this, and this can be again picked up by using certain SVM-based applications based on AI. And these testing, although have been done older children who are above the age of 9 to 10 years, and that is not the age when we need to actually detect these reading disabilities. It has to be picked up at an earlier age. So application of these reading disability tools in an early age is still pending. Then we have the amblyopia. We have a CANA tool, which is come for amblyopia. Basically, it is using the diagnostic criteria given by APOS, referral criteria. And based on this, it is trying to detect the amblyopia risk factors. And 5 ARF risk factors have been used in these. And if any of these 5 exceed the prescribed thresholds which are given by this AI tool, the image is flagged as ARF positive, else it is predicted as AR, the risk of 0. So that does not require any much of specialized instrument in this. This is low cost, can be used in the periphery, can be used in the rural areas, and patients can even test themselves at home as a preliminary screening tool. The limitation is, again, the tool has been developed based on a very small sample size, and if there is an extreme variability in the pupillary size, then the prediction of the refractive error and the media opacities will not be very good with this. And also, astigmatism will cause an eccentric photorefraction, and again, then the prediction value will go down. Then there is something called as a digital pill for amblyopia, which is basically the third part, which is the phase 3, which is the AI-based monitoring, which is basically what we are doing is, like we have started giving home treatments for amblyopia, both in the form of dichoptic therapies as well as patch therapies. So it is basically that the phase 3 of this is an AI-based feedback, or a digital pill as we call it, where emotional expressions, the patterns of eye blinks, eye closures are picked up by this tool while the patient is doing therapy and after that also. And this shows, by detecting changes in these patterns, in any of these variables, it captures the patient's attention monitoring. So how much work did he actually do on that amblyopia therapy which we had given to the patient. So it gives the feedback to the patient directly there and then itself, and also alters the caregivers and gives them the sort of an alarming signal that the therapy is not being done properly, okay? So, and then this is a positive feedback as well as a negative feedback mechanism for improving your compliance to the therapy. Then we have a stereo vision. As we all know, stereo vision, we have the basic stereo vision tests which are there in our armamentarium, which are used obviously in our clinics as a pediatric ophthalmologist. This is a mobile-based app, which is innovative screening solution for testing for amblyopia, stereopsis in amblyopia. And it is basically based on the principle of anaglyphic random dot stereograms. Again, several adjustable parameters are there, and this actually is better than other tools, which outperforms the classical anaglyphic random stereograms for amblyopia conditions. And therefore, again, it has a role in the telemedicine, in the home screening, and obviously in the integration with the basic hospital services as well. Then we have the role of AI in genetics. We have lots of cases now. The genetics is booming up like anything in pediatric ophthalmology. We're trying to find gene therapies for most of the diseases, which are like, till now we did not have any solutions. The latest thing, which obviously is our gene for RP65, which is used for LCA, for various types of RPA, and then lots of gene studies going for other congenital glaucoma as well. So basically, to have a genotypic correlation is very important. So AI doing it on a manual basis is going to be very, very difficult. It is not possible for a human mind. So we are trying to train AI models using the fundus images as well as anti-segment OCT images to identify the glaucoma, for glaucoma I'm talking about right now, for congenital glaucoma, to identify the glaucomatous changes. And then the same existing lookai using the GWAS of these patients, which is the word by genome data which is available to us. We can use the future AI applications to find this correlation, and then probably can develop further which children actually need to be taken up for further genetic studies and further enrolled into gene therapies trials, and all that can be picked up by these. Similarly, we have the inherited retinal diseases. I've already talked about the same way the process is being done for inherited retinal diseases, and also for the optic neuropathies, which is the inherited optic neuropathies, including the Leber's, as well as for the other optic neuropathies. Then we have for visual rehabilitation, we have the AI, which is the assisted technology, which has come up for visual rehabilitation for children who are actually visually disabled. We have the ORCAM-MI, or the Seeing AI, which is again AI-powered recognition, which helps in the object recognition as well as the optical character recognitions. And it gives the power to the visually impaired children and enhances the ability to interact with the real world. We have the smart wearable eye tracking devices, which is the e-sight of the eye controls. So what is the social impact of all these AI devices on the visually disabled children is basically improves their quality of life. They're able to navigate in the normal real world. And especially if we intervene early, they may become cost effective. Right now, they're not very cost effective, but they may become cost effective as more and more awareness comes, more and more social involvement comes, and more government aids come to us. What are the future potentials in these cases is obviously we can use the visual reality and the augmented reality systems which we are using in our various amblyopia therapy tools as well, and can personalize them for each child according to his visual disability. and for predicting the outcomes, which children will benefit from these tools or what type of therapy they may benefit from. And we can try to collaborate this with the schools also to give them the better training according to their visual disability. And also for the use of and also incorporate the robotics to help them in their visual motor training, because sometimes these children are not only visually disabled, they also have certain motor functional deficits. Thank you. I think the other two speakers have not come, so, but the topics can be taken up. So anybody, if anybody has any questions related to amblyopia or on my talk itself, we can take those questions.
You know, these AI tools which I mentioned, are they available at the present moment, or?
For ROP, they are being used, but again, as I said, for ROP, there's a lot of, the performance has been poor than that of the experts, because they're actually using the vessel segmentation. So that is being given by, the tool was developed based on only few experts' opinions. So that's why the performance, when we actually compare, the comparative trials are going on actually. It's not coming to the market as such, but the comparative trials are going on in the clinical phases. CZ Cruiser and for the cataract, they are available. The websites which I showed for the cataracts, they are available. Anybody has any questions on my talk or for amblyopia? If anybody has any questions, we can take questions for that.
I think the AI would have a big role, especially with not that many pediatric ophthalmologists over
Yeah, that's what I said. So we have very few pediatric ophthalmologists amongst the entire ophthalmologists.
Yeah, so like in medical retina, we use it for
so that's why if the apps come, it will become very easy. At least we'll be able to have earlier referrals, early diagnosis and early referrals, so that at least we can visually rehabilitate them in a better way.
I think it would at least take out the normals from the abnormal and say, okay,
yes,
abnormal,
yes,
these are normal, and these need better.
Yeah, that's what I said. So school screenings, rural health screening. So everywhere will be. So that's why I said, no, certain conditions, their tools are giving sensitivity of almost 80% for ptosis, for strabismus. This can be sometimes done by even by Anganwadi because it's basically capturing images. It's only the quality of images has to be good for that AI to decipher them as normal or abnormal. That is the basic function of an AI. AI works on that only. It will classify the image as normal or abnormal.
This was nice, a very nice presentation, and rather this is the future, you know.
Yes.
For AI.
A lot of work is going on. The only thing is the limitations are basically, as we said in pediatric, is capturing the image. You see, better will be the sensitivity, better will be the sensitivity of the AI. So we can have a photograph, sir. Sir, we can have a photograph. Is it an official photograph? Is it an official photograph outside? Excuse me. Is it an official photographer outside? Is it an official photographer outside? Can you just call him if he's there? Otherwise, we'll take it from our phones.